Yes, thank you, Nirav. A very good evening and a warm welcome to all the participants and delegates of the All India Ophthalmic Society. A very grateful thanks to the organizing committee to have included this new international AOS session. And this evening we are having a great session by the American Glaucoma Society. The session is called Heretic but True. Heretical but true. Heretical, I don't know how many of us knew the meaning, but I believe it actually means something that is unconventional or non-conforming. So we are going to have a set of great talks on this, which Dr. Sonia will be moderating from the United States. Let me take a couple of minutes to introduce Dr. Sonia. Dr. Sonia Babashah is a faculty at the Northern Virginia Ophthalmology Associates in the US, and she specializes in cataract and glaucoma surgeries. She has received a training at the Johns Hopkins as well as Wills Eye Hospital, two of the top 10 institutes in the United States. And with a distinguished summa cum laude recognition from the University of Pennsylvania. She has been involved in medical and resident education and training, and currently serves as in the program committee of the American Glaucoma Society and the Northern Virginia Associates of Ophthalmology. I have great pleasure in welcoming Dr. Sonia, and I request her to moderate this great session, Heretical but True in Glaucoma. Thank you, Dr. Sonia, and welcome to the world of AOS.
Thank you so much for having me. I'm honored to be a part of your meeting. I hope you enjoyed this session today. We wanted to speak of some of these bold ideas, which perhaps are becoming true, but are still under great question. So we thought it would generate some good discussion. You'll see in the topics that we're talking about very different things, but we will start with the first talk. And that is glaucoma surgical training. Is trabeculectomy actually, should it be required or should it be optional? So we'll watch Dr. Connie Okeke, who is faculty at Eastern Virginia Medical School in Southern Virginia, and she will tell us her take on that.
Glaucoma surgical training. Should trabeculectomies be required? Reevaluating the training of TRABs by Constance Okeke.
And these are my financial disclosures. Do you remember the rotary phone? Well, back in the day, it used to be the gold standard for communication. I mean, it worked. You could connect with family across the country, but it did take longer to dial, and you might need to use an operator to get connected, but it definitely was immobile. Imagine if we were still using the rotary phone. No cell phones, no smartphones. Well, the trabeculectomy has been the gold standard for over 50 years for glaucoma surgery. It's been the go-to when we really need to get the pressure down despite maximal medical therapy. The question today is, glaucoma surgical training, should trabeculectomies be required? Many of you in a recent survey said yes, TRABs should be part of fellowship training. But today my position is to talk about TRABs not being required, but optional. And I'd like you to rethink TRABs as we go through my reasons why. The first reason is that TRABs have a lot of problems despite their triumphs. We all know that aggressive IOP lowering is very important in slowing down visual field loss. And our goal for glaucoma treatment is to preserve vision. But you and I both know that glaucoma trabeculectomies can cause a lot of complications, and those complications are often vision threatening. Even when the TRABs work really well, like in this study, where TRABs were compared to tubes, and the TRABs in blue showed a much lower IOP with less medication than tubes in orange. But at what cost? In the first year, up to 20% of patients lost greater than or equal to 2 lines of vision, and up to 40% at 5 years. The complication rates were also high at over 40% of either early or late complications. The laundry list of complications with trabeculectomy surgery is exhaustive, and both you and I have likely had experiences with sleepless nights because of something on this list, with our patients that we were trying to do no harm. Also, trabeculectomy is associated with less quality of life and less patient satisfaction because sometimes the eye doesn't feel good with blood dysesthesia or increase in ocular surface disease. We need to move forward and let go of this rotary phone in glaucoma surgery so we can find the smartphone. The number 2 reason is that we also have options, other options that we need to nurture and that we need to allow to evolve. We're in a glaucoma renaissance that started in the early 2000s. Tubes are replacing trabs. With the TVT study, we learned that tubes can actually be even more effective than trabeculectomies. And then over the last decade, we've been going through this explosion with microinvasive glaucoma surgery because we want safer surgery that's also effective. And these MIGS procedures are showing to be effective, like the Ganglion procedures with the GAT. In this 2-year study, it was found that patients who had primary open-angle glaucoma had a 37% reduction in mean IOP, and then with patients who had secondary open-angle glaucoma, the reduction was 49%. And we're doing better in terms of how we are studying these procedures with better trials like the HYDRIS, 2 prospective multi-center randomized trials showing the effectiveness of lowering IOP without drops. And this is showing effectiveness after multiple studies and with longevity. It's also been shown that these procedures are also safe and the safety being compared to cataract surgery alone, with vision being preserved and the complications being low and not vision threatening. The other options that are coming out are subconjunctival stents, and in many instances, these are starting to replace trabs. We're still learning how to perfect this process, but you and I are, based on the survey, using these stents to replace trabeculectomies. SLT as a first-line treatment is also going to reduce the number of surgeries that are being performed. With the LIGHT study, we learned that using SLT first can actually decrease the number of patients who go on to need surgery. So with the tubes, with the MIGS, with the LIGs, with the use of SLT, all of these factors are lowering the number of trabeculectomies being performed, which will be less for our glaucoma surgeons, our fellows, and also with less doctors who are retiring who were trained in trabs, there'll be less for our fellows, and less is not actually a bad thing. Because what would we do if we didn't have all that time and attention towards the surgical learning or the post-operative management learning? We'd actually have time to focus on other important factors. We'd be forced to perfect those options that we have now and focus on the patient selection, the surgical skill, and the post-operative management. And we'd have time to think about those next best options. If we did what we did in the last 10 years with MIGS, can you imagine what the next few decades will look like? We need to be able to focus our approaches on finding mechanisms, using newer technologies so that we can target our treatment. And then we'd also have time to focus on other ways to prevent severe disease, like the basics of awareness and education. We need to train our fellows better communication between patients and doctors, because patients are very important in the role of preventing disease. We also can focus on increasing diversity, because glaucoma is a disease that affects a large population of people of color. Improving the underrepresented minorities in the workforce can actually help and be part of the solution for reducing health disparities. And then all of these factors can lead to earlier detection and then our safer intervention. These problems can lead us to better options. So in conclusion, yes, we need to be thinking about these options and paying attention to them, because the movement of less trabs is happening. It is inevitable and it's necessary so that we can move forward and so we can find that new smartphone for glaucoma surgery. No, trabs should not be required, just optional for now. Thank you for your time and attention on these thoughts.
So I think that was a interesting talk. I hope we can discuss that a little bit more later. Our next topic is a talk given by Dr. Tin Ong, who is an esteemed faculty from Singapore National Eye Center. He was our American Glaucoma Society International Scholar last year, and I'm sure many of you are familiar with his work. So we have the bold idea, primary angle closure suspect, no PIs. Perhaps they are no longer as required as we thought.
Good morning. My name is Tin Ang from Singapore. I'd like to thank the AGS for inviting me to give this talk, as well as for awarding the AGS International Scholar Award. My talk today is on PACS, no PI. I have no disclosures. Angulosia glaucoma is an important form of glaucoma worldwide, especially in Asia. There are several stages of the disease process, starting with angle closure suspects to primary angle closure and finally primary angle closure glaucoma. In the past, the progression rate from PACS to PAC and PACG was not clear, estimated to be around 30% over 5 years. The prevalence of PACG in many Asian populations is around 1 to 2%. However, as many as 5 to 8% of Chinese people above the age of 40 years are PACS. This suggests that most of PACS do not progress to PACG. Let me go through a case, a 59-year-old lady with hyperopia of +2 diopters. She has 20/20 vision in both eyes, a very mild cataract and shallow anterior chambers. Her intraocular pressure is normal, optic disc and visual fields are normal, and gonioscopy shows appositional closure, and this is confirmed on the Visante anterior segment OCT. This is a patient with asymptomatic PACS or narrow angles. So how would you manage this lady? The options are laser PI in both eyes, pilocarpine, bilateral phaco, or observation. Probably most of you will choose either laser PI in both eyes or observation. However, if we choose observation, we worry that we may miss a patient coming back with acute angle closure or chronic angle closure glaucoma in the future. These are blinding conditions. Laser PI is done in angle closure to prevent pupil block. It prevents progression to chronic angle closure glaucoma. However, there are adverse events of laser PI, such as visual symptoms and corneal damage as well as cataract progression. So how do you counsel your PACS patients for laser PI? Should you advise them to do a laser PI, or is there an option of observation and not doing a laser PI? Recently, there have been 2 major trials that have been done to address this question. First was the Zhongshan Angle Closure Prevention Trial, or the ZAP trial, published in 2019. In this trial, they recruited almost 900 patients who had bilateral PACS, and they were randomized to laser PI in one eye and no treatment in the fellow eye, and followed up for 6 years. The primary outcome measure was incidence of primary angle closure, defined as 2 IOP measurements above 24, or the development of 1 clock hour of PAS, or an episode of acute angle closure. In the ZAP trial, the mean age of participants was 59 years. There were more females than males, and most of the iridotomies were placed superiorly. The follow-up was good, with 75% of patients completing 6 years of follow-up. And overall, the study ZAP trial found that the incidence of primary angle closure on the endpoint was 4.19 per 1,000 eye years in the eyes that underwent laser iridotomy, and 7.97 per 1,000 eye years in the control eyes or the untreated eyes. This was significant. A primary outcome occurred in both eyes in 10 participants. In raw numbers, this translates to 2% in the laser group versus 4% in the no treatment group. And the acute angle closure occurred in 3 out of 889 cases, or 0.003%. The risk factors for progression in the ZAP trial were eyes with narrow angle width at baseline. So the ZAP trial results were a bit surprising in the sense that the progression was overall very low, less than 1% per year, and performing a laser iridotomy reduced the risk by about half. Laser PI was safe with no long-term adverse events. Remember, the primary endpoint was the incidence of primary angle closure, particularly the development of PAS, and there were very few cases who developed acute angle closure or primary angle closure glaucoma. So PAS by itself is not associated with vision loss. So the ZAP trial recommended that patients with PACS can be observed because the risk of progression is low. However, acute angle closure can occur in rare cases, especially with pupil dilation. The ZAP trial was, of course, a Chinese population, which may be considered as a slightly higher risk population. In other populations, the risk may be even lower. The ZAP trial had a slightly younger population, about mean age of 59 years, and this is because they wanted to recruit patients who did not have significant cataract. It was also recruited from a community setting in China. The Singapore trial of the Analyst trial was a sister trial of the ZAP trial, and in this trial we recruited about 480 patients and followed up for 5 years, again with a similar trial design of laser PI in one eye and no treatment in the fellow eye. In the Singapore trial, we found that the progression rate was slightly higher than ZAP. 9% progressed in the no PI group versus 5% in the LPI group. Again, the risk reduction was about half. And the majority of those who progressed, again, was PAC. And the incidence of acute ankle closure was, again, very low, only 3 out of 480 patients. The risk factors for progression in the Singapore trial were narrow angles at baseline, higher baseline IOP, higher post-dilation IOP at baseline, as well as patients with diabetes mellitus. So putting the two trials together, you can see that the progression rate really is quite low. If you were untreated, it was about 9% in Singapore versus 4% in the ZAP trial. Why the difference between the two trials? Well, Singapore is slightly more multiracial with a few non-Chinese participants. The Singapore study also were recruited from a hospital setting compared to the ZAP trial from a community setting, and the angle width at baseline was slightly wider in the ZAP trial. So how have these trials affected management of PACS? Well, it gives us good evidence of the low risk of progression. And as I said, most of the endpoints were PAC, and certainly raises the question of whether we are overtreating PACS when we recommend LPI for both eyes. Right now, I discussed with the patient the options of either laser PI or observation. I quote the new trial data and explain the risk of both options and let the patient decide. For older people with cataract, I would recommend cataract extraction, and there's no need for a laser PI. So who should go for laser PI? Well, among those with PACS, I would recommend laser PI for those who are possibly symptomatic or having intermittent acute attacks, those who require regular dilation, especially those with diabetes, perhaps people with poor access or unable to follow up, and maybe people with a family history of Angulosia Glaucoma. So in summary, today I've reviewed the options of observation only in patients with PACS. Both the ZAP and Singapore Analyst trials showed a low risk of progression if you leave the patient untreated. However, I suggest discussing the risk with the patient and let the patient decide. In patients with cataract, we would recommend cataract surgery. I'd like to acknowledge my collaborators Ming Guang He, David Friedman, and Paul Foster, and the Singapore team who were involved in the Analyst trial. Thank you for your attention.
I think this talk is really interesting. I think it will change a lot of our practice. General ophthalmologists often will be the first people to see asymptomatic narrow angles, and I already see that change happening in our practice. Our next talk is from Dr. Yvonne Oh. She's in University of San Francisco faculty who does some wonderful basic science research. And her talk is on how glaucoma is not only a pressure-dependent optic nerve disease.
I'd like to thank the AGS Program Committee and Drs. Coleman and Shah for inviting me to give this talk. I have no disclosures. H.G. Wells said that heresies are experiments in man's unsatisfied search for truth. And while I don't think I'll be saying anything heretical today, I do want to discuss experiments suggesting that glaucoma is not only a pressure-dependent optic nerve disease, but it is also a pressure-independent retinal disease. So the evidence for eye pressure-independent factors includes the fact that nearly 40% of open-angle glaucoma patients do not have elevated IOP, suggesting that IOP-independent risk factors are playing a major role. We also know that low ocular perfusion pressure, both diastolic and systolic, but here I'm highlighting evidence from the early manifest glaucoma trial, showing that low systolic ocular perfusion pressure is associated with higher risk of glaucoma progression. And of course, ocular perfusion pressure is not fully divorced from IOP, but we know that vascular factors are likely playing an important role. We also know that the low tension glaucoma treatment study demonstrated that brimonidine, a neuroprotective agent demonstrated in the laboratory, resulted in less visual field progression compared to timolol, despite similar IOP lowering. Glaucoma is also a retinal neurodegenerative disease, and I'll focus on two aspects: compartmentalized neurodegeneration and ganglion cell type susceptibility, and how this information can lead to new biomarkers, including novel imaging and functional assessments. Now, there are many types of ganglion cells, but one functional distinction are the on versus off ganglion cells. The on ganglion cells are responding to light increments, whereas the off ganglion cells are responding to light decrements. And they stratify differently in the inner plexiform layer, as shown here in the red and blue cells. I'll be focusing on two of these types, the on-alpha sustained ganglion cell and the off-transient alpha ganglion cell. And these two represent a nice dichotomy between on and off. In a mouse model of elevated IOP, our group showed that after transient eye pressure elevation for 7 days, after which eye pressure returns to baseline, the alpha on sustained ganglion cells actually maintain their dendritic area and even increase their receptive field radius, whereas the alpha off transient ganglion cells shrink, both in terms of dendritic area and their receptive field radius. However, despite the fact that alpha on sustained ganglion cells maintain their dendritic area, they lose their synapses, and that's quite apparent here based on these heat maps, with red for high density in the control and blue representing low density in the eye pressure elevation condition. And this occurs as early as 7 days, as represented by the magenta curve here. And so we know that synapse loss is occurring before dendritic shrinkage, and that represents compartmentalized neurodegeneration, and that synapse loss is an early biomarker of glaucomatous retinal neurodegeneration. So how can we use that information to look at the inner plexiform layer in novel imaging strategies? There are several groups working on this problem using visible light OCT. You know, conventional OCT cannot distinguish between the ganglion cell layer or segment between the ganglion cell layer and the inner plexiform layer. So we have the ganglion cell complex. But visible light OCT can now demonstrate these hyperreflective bands segmenting different portions of the inner plexiform layer, much like we see in histology. And in fact, I know that Dr. Kasabi may have spoken earlier during this meeting about their work showing that there may be differential thinning of various sublamina within the IPL in glaucoma patients versus controls. We also know that alpha on sustained ganglion cells are more resilient after eye pressure elevation. This is data showing that they survive, whereas the alpha off transient cells are lost. So the off cells may actually represent the canary in the coal mine, early susceptibility, whereas the on ganglion cells are like the hardy coal miner, much more resilient. And so are these more resilient ganglion cell types functionally impaired, but able to be rescued? We and others have shown that there's early synapse loss and dysfunction, followed by dendritic shrinkage, ERG amplitude and receptive field size loss, axonal transport deficits, and microglial activation, suggesting that IOP-independent neuroinflammation may be playing a role. To look at this dysfunction, our group decided to use the ERG to directly and objectively measure changes in the on versus off pathways. This has been explored with other ERG modalities, and there's evidence that a flicker stimulus can be used to separate the on versus off pathways, with the off pathways being dominated at the higher frequencies, shown here in purple. We enrolled patients into a study using the handheld Redival device to measure ERG responses. And we used a custom-written sinusoidal flicker wave pattern of light, high frequency and low frequency. These are example waveforms from a patient and show that at high frequencies, there is a decrease in the ERG response, shown here in orange, as compared to the control in gray, whereas at low frequencies, there is no difference. And this was true when we looked at ERG responses as a function of stimulus frequency, with greater separation at the higher frequencies, And when we looked at lower than 10 hertz versus greater than 10 hertz, glaucoma patients exhibited a decreased ERG response. And so our current paradigm is that glaucoma exhibits optic nerve damage as evidenced by optic disc and retinal nerve fiber layer or visual field abnormalities. And it is my hope that in the near future, glaucoma will be defined as exhibiting both optic nerve damage and retinal degenerative changes, and that we will be able to measure these with novel functional and imaging studies. So I'll end with a quote from Helen Keller: "The heresy of one age becomes the orthodoxy of the next." And I'd like to thank members of my lab team. Here we're doing a virtual escape room, and highlight Alan Kong. He'll be applying for ophthalmology residency this fall, who spearheaded the ERG project. I'd like to thank you for your attention, as well as my funders.
Very interesting talk on the retinal aspect of glaucoma, which I think is becoming more and more recognized. Our next talk is about early glaucoma with Dr. Henry Jampel at the Wilmer Eye Institute at Johns Hopkins. He argues that perhaps early glaucoma need not be treated, and he will give us his thoughts on this.
This is Henry Jampel, and I want to thank the organizers for inviting me to participate in this heretical session. The topic title I was assigned was "Early Glaucoma Should Not Be Treated, Period." I have taken the speaker's prerogative of slightly modifying this title, to emphasize the fact that we don't treat glaucoma, we treat the glaucoma patient, and then second, removing period because there are exceptions to this dictum. My argument is as follows. We don't really know what early glaucoma is. Treatment, at least of ocular hypertension, can be delayed without harm. The effectiveness of treatment of early glaucoma is modest. Furthermore, treatment has not been shown to preserve quality of life. Most patients with early glaucoma do not live long enough to lose important vision, and all treatments for glaucoma have side effects. We don't really know what early glaucoma is. Is it elevated intraocular pressure alone? Is it an abnormal disc appearance or OCT with a normal visual field? Or must it include visual field loss? This question remains to be answered definitively, but Dr. Quigley and his international colleagues are attempting to provide us all with a better definition of glaucoma. Nevertheless, here is an example I think we can all agree upon. This was a 63-year-old male who I just saw recently. He had been followed for years by an ophthalmologist who told him he was fine. The ophthalmologist retired. He was then seen by an astute optometrist who thought he might have glaucoma and referred the patient. The OCT shows characteristic thinning of the superior retinal nerve fiber layer, accompanied by a corresponding inferior visual field defect. His intraocular pressures were repeatedly between 13 and 16 millimeters of mercury. We will return to him at the end of the talk. Second, the treatment of ocular hypertension can be delayed, and perhaps by extrapolation, early glaucoma. This graph from the Oates study follow-up demonstrates that when the control group, who was not treated for 7 years, then was treated, that its course was no different from that from the subjects who had been treated from the start. Therefore, withholding treatment for 7 years did not adversely affect the subjects who were not treated. 3, the effectiveness of treatment of early glaucoma is modest, at least in the early manifest glaucoma trial. In this trial, patients with early glaucoma were randomized to treatment or observation. At 6 years, the worsening was 49% in the treated group and 63% in the untreated group. This leads to a number needed to treat of 7. In other words, one needed to treat 7 early glaucoma patients to see a beneficial effect in 1. We see a similar phenomenon in the United Kingdom glaucoma treatment study, where patients were randomized to latanoprost or placebo. At 2 years, 15% of the treated group had worsened, and 25% of the untreated group had worsened, for a number needed to treat of 10. 4, treatment has not been shown to preserve quality of life. Again, from the early manifest glaucoma trial, the quality of life at 3 years into the trial was the same in both the treated and the untreated group, both for the composite the composite score and for the subscale scores on the NEI VFQ. 5th, most patients with early glaucoma did not live long enough to go blind. This graph is from Broman and others. They modeled the average age at which glaucoma was diagnosed and compared it to the average age at which a glaucoma patient died, and found that in the worst case scenario for African derived individuals, the average time from glaucoma diagnosis until death was 15 years. For other ethnicities and races, it was less than 15 years. 6, all treatments for glaucoma can have side effects. This graph, also from the EMGT, showed that the onset or progression of cataract was higher in the treated group than in the control group. So, is it ethical to not treat the early glaucoma patient? I would argue yes. The decision to treat should be based upon an analysis of the risks and benefits of treatment, not just the benefits. The EMGT and the UK-GTS did demonstrate the benefit of treatment, but they did not offer a risk-benefit analysis. Clearly, any decision whether to observe or treat the patient with early glaucoma should involve the patient in the decision-making process. There are exceptions to the don't treat rule, of course. If the intraocular pressure is really high, the patient should be treated. But recall, many of these patients do not have elevated intraocular pressure. If the patient can't stand the thought of having the disease that is not treated, then the patient should be treated. Or if you observe the patient getting worse over time, or historically, if you know the patient used to be normal and then now has early glaucoma, one would likely treat. In summary, don't treat the early glaucoma patient. The definition is vague. There is time to treat later. The treatment effect is modest. There is no evidence that treatment affects quality of life. Most patients won't live long enough to lose important vision, and treatment has side effects. And the patient from earlier, after extended discussion, he elected to be treated. I prescribed latanoprost for the right eye and scheduled a return visit in 3 months with repeat visual field testing. 3 hours later, he called me and wondered if he could hold off on the eye drops for now. And of course, I told him yes. Thank you for your attention.
So very interesting thoughts there. I think we have been traditionally told that as soon as we see signs of glaucoma, we may want to discuss with the patient about starting treatment in order to prevent visual loss. But is that really necessary? That is the heretical or the bold question there. Now our final talk is by Dr. Janet Searle, who is faculty at Mount Sinai Hospital in New York. She is a very recognized worldwide leader in the development of many ocular hypotensive medications. But she actually talks to us about glaucoma treatment, medications not required, perhaps.
Hello, colleagues. I'll be discussing whether we can manage glaucoma without ocular hypotensive medications. These are my disclosures. We do have many treatments that lower IOP instead of or in addition to medications. The traditional options that we are well familiar with are listed here. Recently, there has been an explosion in the number of surgical procedures and devices for lowering IOP in a less invasive manner. Most of these devices are listed here. New ones are on the horizon. We continue to define the range and duration of efficacy of these newer devices. The goal of glaucoma treatment is to achieve an IOP that prevents progression and achieves stability in each and every patient. Target IOP guidelines have been established from many large prospective clinical trials, and recommendations have been prepared by the American Academy of Ophthalmology, the European Glaucoma Society, and others. The guidelines for setting target IOP are listed here. These are general guidelines, and in each patient, it is important to assess risk parameters in addition to stage of disease. Once identified, in some patients, we can hopefully get ahead of progression, treating more aggressively, and in other patients, we may be able to step back, accept higher target IOP, and carefully assess the most appropriate therapies. Once we set a target IOP, how effectively can we achieve it, and with which non-medical treatments? The range and duration of efficacy with alternatives to medical therapy has been evaluated in many studies. SLT as a primary procedure in newly diagnosed patients has been carefully assessed in the LIGHT trial. During 3 years of follow-up, mean IOP was 16.6 millimeters of mercury. 78% of patients remained stable without ocular hypotensive medications, and 77% of patients required only one SLT. It's important to remember that more than 80% of the patients enrolled were diagnosed as ocular hypertensive or mild glaucoma, so the results of this study may not apply to all of our patients. Target IOP was defined as a reduction of 20% or 30% from baseline, depending upon patient characteristics. Prior to the introduction of MIGS, cataract surgery alone was observed to lower IOP. The control groups, cataract only, in the COMPASS and HORIZON studies supported the finding that some patients do have sufficient IOP control and do remain medication-free following cataract surgery alone. Although the number of patients with adequate medication-free IOP control post-cataract extraction alone is smaller than the number of patients who had a MIGS device added to the cataract surgery. Additionally, IOP reductions wane over time, particularly following cataract extraction alone, as you can see from the data here. The MIGS literature continues to expand. The number of available devices continues to increase. Intraocular pressure following these devices ranges from 11 to 20 millimeters of mercury, with patients on anywhere from almost none to 2 to 3 medications. Most often, intraocular pressures post-op are in the 15 to 17 millimeters of mercury range. So some patients will remain medication-free for a period of time post-op. The large range of observed efficacy and duration is due in part to patient selection, procedure selection, and the surgeon's technique and experience. The more invasive surgical procedures, such as antimetabolite enhanced filtering surgery and CTONs, demonstrate IOPs post-op that are often lower, in the low to mid-teens, with reduced medication requirements. And these studies that are well known to all of us do have follow-up of up to 5 years. We are well acquainted with the risks and benefits of most of our options, so each of us needs to consider whether the current order by which we select treatments is best, or if the order needs to be modified. Should we be considering more often an earlier laser trabeculoplasty, and maybe MIGS also when appropriate? We need to carefully consider when and if a patient needs a more aggressive treatment, particularly our young patients who have a long lifespan ahead of them. Another challenge for our community as a whole is to find and diagnose early disease, to find these patients with glaucoma. I don't think it's yet time to abandon the traditional, more invasive procedures, as these do more consistently result in lower IOPs. Despite the many non-medical options for managing glaucoma, we cannot at this time achieve successful IOP control in all patients without medical therapy. As we look at this list of ocular hypotensive medications, we and our patients are very fortunate to have many choices. We have excellent solo agents, combination drugs, and the recently approved bimatoprost intracameral implant. There are other classes of compounds and devices for lowering IOP under investigation. In order to achieve glaucoma management without eye drops, we need first to find a more robust means of identifying patients with glaucoma, particularly early in the disease. Patients and physicians need to accept and incorporate other treatment options, some of the newer options, in all stages of disease. And if intervention is sufficient and successful, it may change the progression curve. We need to demonstrate that surgical devices and procedures achieve satisfactory target IOPs for long durations of a glaucoma patient's life. For some patients, the current devices do meet target IOP, but the duration remains unclear. It is and it should be a goal to reduce medication burden as much as possible for our patients, and we all know the reasons why. So think again about all of the treatment options available and think about how you make a selection. For early stage patients, consider alternatives to medications. Moderate stage patients, some may be adequately controlled without medications, and some controlled with fewer medications, due in part to the newer non-medical treatment options. For late stage disease, we need to consider the more invasive surgical options, and we have to do our best to prevent patients from looking like the one on this slide. Thank you.
So the trend towards less medication or perhaps no medication, I think is gaining steam, especially after the LIGHT trial. So I would love for you all to take some time to think about what we've talked about and to ask some questions. We have Dr. Krishnadas here as well. And let's see if we can see what you guys think about all these crazy ideas. I think you're on mute.
No, I wouldn't call them crazy, but definitely heretical, because most speakers didn't have sufficient evidence to back up their so-called heretical ideas. As we await questions, Nirup, let us know if there are any questions, but probably I can kickstart the discussion with Dr. Sonia regarding the first talk by Okeke. No doubt she had a very persuasive argument that traps probably should not be given the critical option of as a major surgical option in the training period, but many of us in the developing countries like India and Africa now would probably not agree with that because for the fact that still now we continue to fail to diagnose glaucoma at an earlier stage, just as what Dr. Surley was warning us. And most of patients who come to us are either moderately advanced or fairly far advanced. And other options like MIGS or canal-based surgeries cannot be, we at least do not have evidence that they would be hugely successful in advanced disease when distal outflow pathways are pathological as well. Most of these surgeries, either MIGS or canal-based surgery, they just address the pathology in the trabecular meshwork or the Schlemm's canal, which are too proximal, and they do not take care of the distal outflow pathologies. So given that situation, what would be your opinion regarding the trabeculectomy training? We believe that we are not yet there. We are still hugely dependent upon trabeculectomy for most of our eyes in this part of the world, in the southern part of the globe. So what is your opinion, and does this hold good in the United States? Do you still believe that trabeculectomy can be receded as surgery of choice for training?
Great questions. Obviously, I think the stage of the makes a big difference. When you have the diagnosis early, or if you have more of the cataract and they have myoclonus diagnosed later, of course, you want to have a more definitive procedure. We all know sometimes, and there are many complications that can happen. And especially not the follow-up. Dr. Okeke may argue you should be leaning towards tube shunts instead. There are, of course, complications with having hardware in the eye that you don't have with trabeculectomy, but you don't have complications. But yes, I agree that
Nirup, is Sonia audible?
Yes, I think there's a network issue from ma'am's end.
Oh,
so
let us wait for that.
In the U still.
Yes. Yes, Sonia, go ahead.
I'm sorry about that.
Yes.
Let's try this. Okay, so we were saying about in the US, the trabeculectomy rate has decreased. And I think the less patients are accepting, they have the luxury of saying,
ma'am, please switch off your video.
Trabeculectomy, and I want to try the smaller surgery.
Sorry to interrupt, doctor. Could you please turn on your video and then speak so that the audio would come clearly as the network consumes? Yes. So in that way, that would be a smooth process.
Okay. Is this okay? You want to turn off the video?
This is okay, but in between, the voice is actually fluctuating because of the network. So I would suggest if you could turn off your video and then speak and then turn it off back again, that would be great. Yes. Could you please speak?
Okay. So this is this better now?
Yes.
Yes.
Okay. How's this now? I apologize. Okay. So I'm sorry, what was the last point you were able to hear clearly?
We were talking about the TRAB in the US, that has been declining.
Were you able to hear my thoughts on TRAB?
Just to summarize?
Yes. So I think there are, yes, to summarize that, I think TRABs are declining, and I think there are less to train the fellows. So I think in general, we're going to see more MIGs and tubes taking over here, at least.
Yes. Yes, Dr. Sonia. Regarding the next talk on the laser PI, it was not so heretical because, again, Dr. Ong presented the evidence so very well, and that reflects what we have been doing clinically as well, just trying to follow those with the lowest risk factors for possible angle closure disease in the near future for those with narrow angles. But apart from the factors which help us to decide to perform a PI, for instance, those with acute angle closure in the other eye, those with diabetes, or those who require frequent dilatation and family history of glaucoma, are there any other risk factors one could get cues from clinical evaluation like gonioscopy that would tell us, yes, this patient has a primary angle closure suspect without any manifest disease. But my gut feeling says that he or she would probably go in for angle closure disease in the near future, and I would like to recommend laser PI. Are there any clinical cues to decide on this?
I think both studies showed that a narrower angle at baseline did increase the risk of developing progression later on. So when you're doing your gonioscopy, and if you cannot see any angle structures, if it's only Schwalbe's line or even narrower than that, I think that should be a clinical cue for you to perhaps recommend PI or very, very close follow-up. There are some patients that previously we would consider narrow who have perhaps, anterior trabecular meshwork visible still, but they're very bowed. Or a plateau configuration. I think these people are at higher risk. So perhaps doing a PI in these people. And then he also mentioned that people of Chinese descent are a little bit more likely to go into angle closure. So, and then in general, other than the gonioscopy, I think it's very important to ask about medications that people are on. There are some medications such as antidepressants or nasal sprays that have some, anticholinergic effect that they can narrow the angle. And so if they're frequently on those medications, I often will go towards PI.
What is the clinical gonioscopy technique you would suggest? Indentation, or would you suggest an indentation gonioscopy to decide whether a person requires LPA or not?
Absolutely. I think indentation gonioscopy, every time indentation, because you can see the development of PAS, of anterior synechii, and any anterior synechii is, I think, an indication for PI.
But Sonia, most narrow angle eyes, when you indent firmly, they do open up, at least up to trabecular meshwork. So is it very easy to decide clinically about the impending risk?
Yeah, I don't think it's a clear-cut answer. Absolutely, there are.
Okay. Regarding the talk on pressure independent factors, do you believe there is any therapeutic measure one could think of as of now, evidence-based, which would address the pathophysiology of glaucoma other than reducing the intraocular pressure?
At this point, I think the only evidence-based thing is trying to increase ocular perfusion pressure. So people who have very low blood pressure, perhaps recommending salt intake at nighttime. But other than that, I do not think we have treatments that would specifically address the retinal neurodegeneration, although I know that's being studied.
Okay. Sonia, on a related note, from a patient's perspective, somebody with, say, a moderate to advanced disease, does diet or exercise have at least a minor role in as a associate factor in treatment in helping us to address the disease progression?
That's a great question. Patients ask that all the time, and I tell them that because diseases such as diabetes and hypertension are associated with glaucoma, it is of course helpful to have a good diet and to exercise, because decreasing your blood sugar and blood pressure can be very helpful to the health and the blood flow to the eye. I think there's also evidence to show that dark green leafy vegetables in the diet are very, very good, and they have nitric oxide compounds that help decrease progression. Other than that, I don't think we have a lot of evidence-based medicine to point us towards it, but I think in general, these are very harmless things you can tell someone to do.
Great. Henry's talk was very encouraging, that we can let alone patients with early evidence of disease. But on the contrary, in many countries, the longevity is increasing, the demographics are changing. We are having more and more people with the elderly population. So even those with probably early glaucoma in their 40s or 50s are likely to live longer these days, up to 80s or 90s, which would leave probably 40 years of exposure to risk factors like reduced perfusion or higher intraocular pressures. With this in mind, would you still be bold or courageous enough to defer treatment of those with early glaucoma? I'm speaking for communities like in Asia and Africa, where one hand, diagnosing disease at an early stage is very challenging. Number two, the follow-up for progression. Many of these patients probably may not follow up over a period of time. So do you think Henry's suggestion, good, he said period, which is good, but do you think his suggestion of observing rather than treating early glaucoma in communities like India, Asia, and Africa is good? And what, in your opinion, is the what is your opinion regarding Henry's suggestion?
Yeah, I think you're the doctor. You know what the patients, which patients perhaps you could implement that suggestion, and perhaps you know which patients may not be able to follow up. You must be able to follow up. If you're not going to treat early glaucoma, I think then you have to meet a patient. You don't know if they are a fast progressor or a slow progressor. And if they are a fast progressor, and especially they're young, I think you must treat. But you don't know that unless you follow them early.
Okay. On a related note, Dr. Yes, Sonia, please go ahead.
In the beginning, I think close follow-up is important, and then you can sort of tailor the treatment. But I think young patients who may not, they are always on the treatment.
Yes, Sonia, thank you. On the related note, Dr. Serly's talk again, obviating the need for medications. I think probably she also justified that it probably is true in early disease, and she emphasized the need for detecting glaucoma early. Again, the challenges in the southern communities, like Asian and African countries, this is going to be very challenging. So let alone these communities, what do you think is the situation in the United States? Do we still have evidence that apart from SLT probably has some evidence that it decreases intraocular pressure for a few years without need for medications? Do we suggest in countries like Europe and US the need for early intervention with MIGS rather than going in for medications in early to moderate glaucoma?
I think if the practitioner, if the doctor is comfortable with that suggestion, there are some patients who are willing to go for early MIGS. I think SLT is becoming much more common, but then going to the operating room tends to be difficult, I think, to convince patients to say, hey, I'm going to go to the operating room instead of just trying an eye drop first. But if someone has a visually significant cataract, you can make the argument, I'm not going to put you on eye drops, but let's go take care of your cataract. And then at the same time, I'll do some MIGS. And I think that is becoming more common. But just MIGS alone before trying medication, that's still not commonplace.
Thank you, Sonia, for your such wonderful responses. Nirup, do we have any questions? I don't see any. A testimony to the fact that the session and Dr. Sonia's moderation was so wonderful.
No, doctor, we don't have any questions from the attendees as of now. And it's 7:58.
Yes, it's 6:58. 7:58. Yeah, sorry. Yeah. Yeah, Sonia is on the video. Thank you, Nirup, for your help in assisting in conducting this session. And many grateful thanks to Dr. Sonia, who has joined us from the US on a wonderful Sunday morning. I know how really difficult it is for her to do that. So Sonia, on behalf of the organizing committee of the All India Ophthalmic Society and Indian ophthalmologists, we really thank you very much. And we really hope to see you sometime in a physical conference of the All India Ophthalmic Science or the Glaucoma Society of India. We would extend you an invitation when physical travel and such conduct of conferences possible in the next couple of years. So thank you very much, Nirup, and thank you, Sonia. Thank you very much.
Thank you.